It causes earlier initiation of medication. It causes greater functional disability, so we require more help in doing daily activities. It is associated with faster physical and cognitive decline. In general, these patients often rate a poor quality of life, probably in part due to the depression, which is associated with poor quality of life in general, with or without Parkinson's, and then also the faster physical and mental decline. And often the caregivers of people with Parkinson's often report more distress, more difficulties, and more concern. Depression is often under-recognized by the patient. The patient may just say, oh, I'm just sad because I have Parkinson's, but that's actually not the case. It's actually a separate issue, as not just a reactive issue. And it's also under-recognized by the provider. We probably don't spend enough time on it during our visit. There's so many other things that we have to spend time on. And so because it is under-recognized, it's also undertreated. There's also often still a stigma attached to depression, attached to using medications, seeking professional help for the issue, so that also overlays into it. So when you treat these patients with depression, you get a lot of improvement in symptoms, and not just the depressive symptoms that people report, but it also comes with less physical disability. People report that they're actually able to do more things all of a sudden, and it improves their quality of life, not even addressing any of the motor symptoms, the stiffness, the slowness, anything like that. And so we do see that depression is often associated with a higher rate of cognitive dysfunction. And in fact, when you look at cognitive function in people that don't have Parkinson's disease, we have something called pseudo-dementia. And pseudo-dementia is an entity where people complain that they actually have mental slowness, they have difficulty remembering things, they're just not as sharp as they used to be, but it's actually a consequence of depression and not real dementia. And once you treat the depression, that actually resolves. These patients often have more sensory complaints or somatic complaints. They complain of more nausea, they complain of more pain. So headache, joint pain, body pain, muscle pain, stomach ache, things like that, neck pain. So depression is associated with somatic pains, and I think there may be kind of a circular effect on that. So people with more pain have more depression, and then people with more depression also have more pain. It's also associated with a lot of anxiety as well. And so in studies, they've seen that depression is more severe and more predominant in people who have more severe motor symptoms, more wearing off. What's called the stage of Parkinson's is worse. Sometimes even younger onset patients have a higher rate of depression, potentially because they have higher disability earlier on in their life when they're still working. And then also people with a higher rate of autonomic symptoms, which are things like urinary complaints, blood pressure changes, a lot of pain. Pain is also an autonomic symptom. So going into what we think is causing depression in Parkinson's disease, and we do think a large portion of it is reactive. So reactive meaning it's in a reaction to having the diagnosis of Parkinson's, so this feeling of being demoralized, feeling anxious about what's going to happen, being fearful about the disease itself and what it involves and what it means for you 5 years down the line, 10 years down the line, or even 1 month down the line. Its impact on your life, its impact on people around you's lives, and also the disability that's involved in it. So there's a lot of chemicals involved in the system. We know that not just dopamine is involved in Parkinson's disease, and not just dopamine is involved in depression. There's 4 major systems. Obviously, number 1, dopamine, so the dopaminergic system. Number 2, the noradrenergic system, or noradrenaline or norepinephrine is involved. We have serotonin, which is implicated largely in what we can call kind of run-of-the-mill depression. And then also acetylcholine is also involved to a small extent. And these four systems are involved in regulation of mood and reward systems. So the feeling of pleasure, the feeling of happiness when you do something that is rewarding to you, either mentally or physically or financially or whatever. So we think that the limbic dopaminergic neurons, which are kind of in your temples, that's where the limbic zone is. These neurons cause dysfunction in the front of your brain, in the frontal lobe, and then that area is also then connected to the base of your brain, the midbrain, where the serotonin is produced, and so it disrupts those neurons in producing serotonin and kind of that chemical signaling. That in turn can cause decreased dopamine transporter activity on its own without having to take into consideration the Parkinson's disease. It causes decreased blood flow to the front of the brain, which is involved a lot in mood and emotional regulation. And that is in fact connected to the basal ganglia, which is the middle of the brain, which is the part of the brain that we are most concerned about, which is involved in movement. And that kind of metabolism of the basal ganglia is reduced when people are depressed. We also often see that people who go through DBS surgery, sometimes we're able to reduce the medications afterwards. And in reducing the medications, in reducing the dopamine, we create almost like a dopamine withdrawal type of situation. And people may temporarily report that they are more depressed. But that does resolve. So that is even more proof that dopamine has something to do with depression, even though for a long time we've considered depression to be a serotonergic problem. And interestingly, there is a genetic link. So even people without Parkinson's who have depression, their first-degree relatives are more likely to have depression as well, especially if they have major depression or severe depression. And depression is at higher rates in unaffected first-degree relatives of people with Parkinson's, suggesting that there is some sort of genetic link. And they've seen that with, LRRK2 mutations, the Parkin mutations, and things like that. So what are the symptoms that we're looking for? Symptoms that we're looking for, people often complain of low mood, feeling very down, feeling very low. They have a diminished ability to enjoy the activities that they used to enjoy. They have a decreased line in just baseline interest level in everything in general. I have a lot of patients report that, they don't do their Tai Chi anymore, or they don't go out to their book club or their biking club or something like that. And many of them say that it's because they're limited because of their physical abilities. But a depressed patient, a depressed person with Parkinson's will then also fail to seek new activities to enjoy, activities that they are not limited in doing. And so that is one of the keys, where they don't divert their attention, they don't divert their energy into doing something else because they don't have that energy anymore. And that's what we call apathy or anhedonia. These patients are often very pessimistic. They think a lot about the negative things and just think about all the negative things that could happen to them. They're often more tearful, they feel hopeless, and they also may feel a little bit of guilt as well. So when we're talking about those symptoms, what do we do? How do we treat it? It's a multiple pronged approach. One of the key ingredients is using medications when appropriate. Another one is therapy, which I'll get to in a minute. And then the last one is just kind of finding your support group, your support village. So going back to medications, all depressants are actually effective. The ones that have been tried, at least in Parkinson's disease, and have been shown to be effective include things like venlafaxine, or you may know it as Effexor, desipramine. I don't even know the brand name of that. It's a very old antidepressant. Citalopram, which I think brand is Celexa. That has also been shown to be effective, and paroxetine, which is Paxil. That's also effective, but those are just the ones that have been tried, not necessarily the only ones that will work. So depending on you, depending on your movement disorder specialist or your neurologist, you may be picking something else, also depending on what else is going on. If you also have sleep problems, if you also have, you want to lose a little bit of weight, or you want to, if anxiety is also a big problem, or OCD or impulse control, it changes the choice that you will pick. It takes, unfortunately, about 8 to 12 weeks to really start to work, and then after which you can kind of titrate the dose depending on your symptoms. Other than medications, at least antidepressants, traditional antidepressants, people are also starting to use a little bit of dopamine agonists, so that works as well. In particular, they've studied pramipexole, which on brand is Mirapex. Some of you may know it as Mirapex. That is the only dopamine agonist they tried. That doesn't mean that all the other ones may or may not work, but there is also some evidence in using that as well. They've done some trials on transcranial magnetic stimulation, more so in the non-Parkinson's population, but also a little bit in PD patients. It's a cap of magnets. They kind of rotate and creating a magnetic field that stimulates your cortex. And that somehow does help with depression. It's just a matter of finding a center, knows what they're doing, knows where to place the magnet to do that. And also electroconvulsive therapy, or ECT. It's been around for a long time. It's actually extremely, extremely effective for all sorts of depression, including Parkinson's depression, and actually has been shown to help with motor symptoms, so the stiffness, the slowness, not only the depression, which is very, very interesting. When you're given a prescription for an antidepressant, some of you may be on rastagalene, or what we know as Azilect, and there's always this concern. The pharmacist may refuse to give you the antidepressants or be concerned about the interaction between the antidepressant and rastagalene. That risk is unfounded, is entirely theoretical and hypothetical. We have given antidepressants and rastagalene to thousands upon thousands of patients, and not one has had an interaction and had what's called serotonin syndrome, which is basically just an overdose of serotonin. So that is something that we don't have to be worried about, which is good. It can be an issue if you're on selegiline or Eldepril, which is the older generation form of rastagalene. So if you're on that before you go on something by your psychiatrist or your neurologist, make sure that you discuss it with your neurologist, okay? The second part that I mentioned was therapy. So not just therapy, but education about how depression relates to Parkinson's disease. Cognitive behavioral therapy, for short CBT, is very successful. It's not studied as rigorously as medications are, because it's a little bit of a harder thing to study, because part of it is very, very subjective. You can use it alone, or you can use it with medication, but in general you go to maybe 12 or 10 or 12 sessions. And in a trial that they did where they had a group doing therapy alone, not therapy alone, therapy with medications, and the group where they did medications alone, comparing the improvement after 10 sessions in about 14 weeks, they did show that the group that got therapy improved in symptom severity by about 56%, while the group, which we can call the placebo group, which only got medications, improved about 8%. So you can see how there is a big improvement, and they kind of work in conjunction. The medication and the therapy kind of work together, and it's not additive. It's not quite exponential, but it's definitely more than additive. So the things that they'll go over in therapy include behavioral activation, just kind of trying to get you out of the slump, if you want to call it that. What's called cognitive restructuring, so kind of reordering the way you think about and approach your world, so that you can kind of try to overcome the depression, not just chemically, but volitionally. They'll teach you anxiety management techniques because anxiety is a huge, huge impact on depression. We'll go over sleep hygiene. Sleep is very, very important in depression. If you don't sleep, you're more likely to be depressed. And also it's a form of support for the caregiver as well. So the caregiver not only goes, but the caregiver will learn also what kind of techniques that you're learning, what they should be doing to help you with your depression. And it really helps. I've seen it help greatly. Other than that, it's really finding also your emotional support. So groups like this, exercise groups, support groups, going to meetings, educating your family, educating your caregivers, educating your friends so that they can give you the support and the assistance that you need. That's also very important in treating depression. So I think that was what I kind of wanted to go over today. If you guys have any questions, I'd be more than happy to answer them. We still have half of our time left, so.
Great. Yeah, we do have a couple questions in the queue. The first one is a person more prone to depression with PD if this person has had depression in their life earlier before the PD diagnosis?
Yes, that is true. So a person who has depression beforehand, even if it resolves, is more likely to have depression again, or what we call relapse, the depression after you have the symptoms of PD.
Okay, great. And is there a differential correlation between Lewy body dementia and depression?
So Lewy body dementia is a slightly different disease, although more and more we believe that it is actually part of the spectrum of Parkinson's disease, where the cognitive problems come very, very early. And we do see a lot of depression in Lewy body dementia as well, because the same pathways are involved. I think more the problem with this population is that they have so much so much cognitive problems early on. They have a lot of communication difficulty. They have a lot more anxiety. So they probably have more difficulty communicating their depression than Parkinson's disease patients, which are a little bit more verbal and able to communicate a little bit more early on.
Okay. If I think my husband is suffering from depression due to his Parkinson's, should we tell our movement disorder specialist, our general practitioner, or which doctor?
I think going to your movement disorder specialist or neurologist would be a really good first step. Although we're not specifically trained in treatment of depression, we do know how to screen you and figure out how bad the depression is. Is this something that maybe we can just start a small dose of medication first, send you to a psychologist or a psychiatrist? But also, telling your GP is also a good idea, because they may have some ideas. They may have really good referral sources for you to go to. So I think in the end, telling both is a good idea, but maybe perhaps start with your movement disorder specialist, because it's very, very linked to the PD. So it's definitely not a separate issue like having high cholesterol or something like that.
Something like that. Okay, great. Could you repeat what you said about the genetic component of depression and Parkinson's? And I just wanted to add in, maybe if you, used a specific family example, like, the father has Parkinson's, what genetically are the children more likely, or I don't know, or just kind of give us like a specific scenario. I think maybe that would help it sink in.
Okay. So there is a genetic component to depression, and then in that, a genetic component of depression related to Parkinson's. So, for example, you have Bob with depression and Parkinson's. So his sisters, his brothers, his children, so 1 degree away, who share probably about half of his DNA, will be more likely to have depression, even if they don't end up developing Parkinson's disease. Does that make sense?
Got it. Yes, that's perfect. Then Judith, I think you unmuted yourself. Is that because you wanted to ask a question out loud?
No, I was trying to make the sound better. I didn't know what I was doing.
Oh, okay. While we have you, do you have a question or should I mute you?
Yes, I've been diagnosed bipolar most of my life, and I've been on medications for depression as well as mania. And it seemed to me after I was diagnosed with Parkinson's a couple of years later, I hit some kind of depression that didn't seem like what I experienced in bipolar depression. Is that true, or just because I knew it was there? And would you treat the depression differently?
So when it comes to bipolar disorder in relating to Parkinson's disease, yes, you are probably going to be more likely to have the depression portion of your bipolar disorder come out more so than the mania. I don't have any specific scientific study that I can quote for that, but it scientifically makes sense that would happen, and it would be treated in the same way with the same medications, but you would just have to be a little bit careful about which antidepressants and what the dose is, because you also don't want to bring out the mania side as well.
Okay, thank you. And thank you for that question, Judith. Diana wanted to clarify, did you say that electroshock therapy is used to treat depression and motor symptoms? If you could clarify.
So electroshock therapy is used to treat severe refractory depression. So depression that doesn't respond to medications, doesn't respond to therapy, doesn't respond to multiple rounds of therapy and medication in different types. It's usually reserved for that because it still has its downfalls and risks as well. So we don't use it on everybody. And it was just, when it was tried in those patients who had depression and also had Parkinson's, they did see that certain Parkinson's disease symptoms like stiffness and slowness got better, but we don't use it for the motor symptoms alone, only when you have depression, severe depression.
Okay, that's an important clarification. Thank you. Let's see. Any suggestions on how to stop anxiety from making worse or bringing about tremors and or dystonia?
Anxiety. I think first we kind of have to separate anxiety into what we call situational anxiety. So anxiety because someone is giving you a hard time and you're having an argument, or you really don't like driving and you have to drive. That is what's called a situational anxiety. And when it comes to that anxiety, I think kind of finding ways to work around your anxiety, or deep breathing exercises, or hanging up the phone, that kind of thing will help a lot with situational anxiety, whereas generalized anxiety, which is just anxiety about everything and nothing, that requires, I think most importantly, therapy to kind of change the way you approach worry and approach being concerned, as well as small amounts of medication. And I usually start with antidepressants actually for anxiety because they work great for both.
Okay, thank you. And Joyce, I see you were unmuting yourself. Is that because you had a question for Dr. Tan that you wanted to ask verbally as well?
Yes.
Go for it.
Well, I actually have sort of two questions. I have Parkinson's disease, of course, and I've had it for 10 years. My father had Lewy body dementia. And what are the chances of me having that? Like, is it hereditary? Could this turn into that? Because I'm always afraid that I'm going to start getting dementia or something's going to happen. You know, I don't know.
So if you've had Parkinson's disease for 10 years and you are on this phone call with me asking a question, you definitely do not have Lewy body dementia, and it's very unlikely that you will develop Lewy body dementia. At this point, the possibility is null or zero. It's not to say that in the future you may have some memory problems, you may have some, problems with attention span or, that kind of thing. But it would be more considered just cognitive dysfunction as a part of Parkinson's disease and not necessarily Lewy body dementia, which we still consider a completely separate entity.
Okay, great. Left, I think that is you who have a question.
Yes.
Okay.
Dr. Tan, I salivate a lot. Anything I can do for that? Excessive salivation.
So did you get that? It was about salivation.
So you have persistent salivation. Is that the question that I'm hearing? And what?
Yes.
So your question is, what should I do, or what should we do about? What do we usually do about persistent salivation? Is that your question?
Yes.
Okay. So that is a very common part. It's really the first question we usually ask is how bothersome it is to you. If it's a little bit at nighttime and you have to change your pillowcase in the morning, and it's not a big deal, we usually don't have to do anything about it. If it becomes more than that, or you're having to hold a towel all the time, or hold a tissue, or it ruins your clothes, or it's a problem when you lean over, then we do try medications for it. There are different types. There's a patch that we use, which is the same patch that we use for seasickness. Actually, it works great. Other things include drops that you put on the tongue. And then if it's still not enough, we can actually use botulinum toxin, or like other versions that you've heard of are Botox, Viamin, Myoblock, and we inject straight into the salivary glands right here that produce the saliva to slow down that production. So we also do that as well.
Okay, thank you. In the chat,
Yes, Botox injection. Yeah. Okay, thank you.
Thank you.
You're welcome.
And we're just going rapid fire. So thank you, Dr. Tan. You are, so impressive. The next question is, have you heard of TMS being used for depression and PD?
I've heard of it, and we don't do it at Cedars, but we do. People do use it. You won't find a specialist who specializes in TMS in Parkinson's. I think that's probably going to be a little bit way subspecialized, but there are places who offer TMS for depression in general. And so that is also a way to go.
Okay, what's TMS? Sorry, I'm not familiar with that acronym.
It's Transcranial Magnetic Stimulation.
Oh, okay, got it. Okay, and there's someone raising their hand. I don't see the name, but it's QT Air 7 is your username. Did you have a question? You can either speak up or type it in the chat. Okay, I think you froze for just a second, Dr. Tan, but it looks like you're back. Can you hear me okay?
Yeah.
Okay. Next question. Targeted specific kinds of exercise therapy has been shown to have clear benefits for non-PD depression, but if the PD depression link is not necessarily serotonin-based, does that mean there isn't the same level of benefit to be gained from exercise in combating PD-related depression?
I think exercise it works for non-PD depression. It also works for PD depression as well. I think it works just as well. We in fact know exercise works for the motor symptoms. There's no reason to doubt that it works for the cognitive and the mood symptoms as well.
Got it. And I think I hear some background noise. Is that our friend Left Hand? Do you have another question?
Yes. What does she say for the medication for excessive salivation? What was the medication that Dr. Tan said was for medication for excessive salivation?
Okay, I think he was just asking for a clarification on it was again the salivation comment, the name of the medication that you mentioned. So
the medications, the patch is called scopolamine. The drops are called Robinol. Robinol, it's actually a Robinol tab. And the injections would be something like Botox, Xeomin, or Myoblock.
Okay.
And those are all botulinum toxins.
I'll type that in your chat, Lep, so you can see that spelled out. And the next question is, are there any antidepressants that interfere with Sinemet or dopaminergic medications?
I'm sorry, can you say that one more time?
Sure.
Oh.
Are there any, it's in the chat, are there any antidepressants that interfere with Sinemet or dopaminergic medications?
There are a few that traditionally are considered antipsychotics or atypical antipsychotics or second generation antipsychotics that people are starting to use more and more for depression, severe depression, bipolar, things like you may have heard of Abilify. That's a big one. What else? Zyprexa, I've heard of once in a while being used. And so those actually have an anti-dopaminergic quality to them. So those are medications that I definitely would not use in my population of patients. But otherwise, all the traditional what are called SSRIs or tricyclic antidepressants, those are all fine to take.
Okay, very good. Any recent research findings regarding efficacy of CBD oil on PD-related depression? would it be an online forum if we didn't have a CBD question? So
CBD oil. So the last research that I saw on CBD or CBD was for sleep, not really for depression. And it did show that it does help with sleep. However, the problem they saw in that study that it actually worsened some depression. And so, but not everybody. So I think when it comes to CBD oil, I wouldn't necessarily see it as the first thing to try in depression. I think it needs a lot more research and a lot more people to try it in a controlled fashion with a certain dose, a certain amount, certain time for quantified depression before I really figure out what it does for that. But I say at this point, since it doesn't seem to be harmful, it's certainly worth a try if that's what you're interested in.
okay, very good. And we have a question from Joyce. I have unmuted your line, Joyce.
Oh, okay. I was typing away. It's not really a question. It's sort of a statement. I was taking Wellbutrin for quite a while, and before that I was taking another kind. I can't remember what it's called. Anyway, I stopped taking it because it said I could gain weight, and so I stopped taking it because I was gaining weight. And I went on Wellbutrin, and I stopped taking all of my medication for depression because I'm not depressed anymore. I've lost 45 pounds. I started exercising. I started moving around. I've completely changed my diet. I don't eat any protein. And I feel so good about myself and about how I feel, how I look, about my Parkinson's. I feel like I feel so good. I can't even explain to you how wonderful I feel. And the reason I feel that way is because I feel like I finally have control of this disease. And that's all I wanted to say.
I mean, that's a great story. I wish everybody here can have that story. And we see that, you know, really changing your life, sleeping better, eating better, exercising better has a large impact, not just on, you know, how you feel physically, but how you feel mentally and emotionally as well.
Very good. Thank you, Joyce. Someone else had a clarification. They wanted to just verify what you stated regarding therapy and medication and which of those is most effective for depression and PD.
I think the combination of both medication and therapy is going to be the most effective for treating depression. And actually, I mean, this is a long time ago, but I read in just regular depression, not PD depression, but therapy was actually more effective than medication, but done correctly. But unfortunately, there's very poor access to that for most areas. So I think medication in those cases is very important then.
Okay, so not in either or, but both.
I think if you really want to treat, if you really, you know, want to treat your symptoms, a combination is going to be the best approach.
Okay, very good. And there's someone else who's trying to chime in with a question. And their screen name is QT Air. So if QT Air 7, if you could type it in the chat, since you're on video only, I can't unmute you since you're video only. So if you could type it in the chat, that would be great. And then the next question And just since we're coming up on 1 o'clock, we're going to be coming to the end of the question session. So if you guys could keep that in mind and type your questions in the chat. But the next one is, my apathy and depression are entirely relieved by the correct dose of rohypnol. I'm sorry, I'm bad at pronouncing these medications. But how can you explain that? How that medication affects the apathy and depression?
So we have seen that depression can be treated with dopamine agonists. The one that they really studied was pramipexole. Ropinirole is also another dopamine agonist, and so it is not surprising to me that depression is treated by ropinirole as well. And so depression and apathy usually kind of come together in varying degrees. And so it is treated with dopamine agonists. And sometimes we do that, especially if there are some motor symptoms that need to be treated. We definitely try to pursue the motor symptoms first and make sure that that is adequately treated before we really try to go after depression in another manner. Because oftentimes, if we just treat the motor symptoms, we get a lot of, we help the mood too at the same time.
Okay, very good. And this is going to be our last question. Is there any correlation between REM, sleep behavior disorder, or poor sleep, and depression? Does one affect the other? It seems like a vicious loop.
Yes, so poor sleep does in fact affect your mood. It affects depression. It actually also worsens anxiety if you can't sleep. And that is a big loop there. You're anxious, you cannot sleep. You can't sleep, then you're more anxious, and you're more depressed, and then you can't sleep even more. So it is a vicious cycle there. REM behavioral sleep disorder itself is probably related to depression. I haven't seen the study directly correlating those two entities. However, REM behavioral sleep disorder, depression, loss of smell, and constipation are usually the herald symptoms of Parkinson's disease years before. So I wouldn't be surprised if that depression and RBD are somehow chemically linked in the brain, because the centers for depression and the center for RBD are very close to each other in the brainstem.
Okay, very good. Well, man, we have just been rapid fire throwing questions at you, Dr. Tan, and you have just handled them all with such expertise and ease. So again, on behalf of PMD Alliance and everyone on this online program, thank you for sharing your lunch hour and all your knowledge with us. If anyone online didn't get a chance to ask your question, email us. I put our email address, it's info@pmdalliance.org in the chat. So still a chance, email it to us. And then we will be posting this on our YouTube channel. So if you missed parts of it or you want to forward this to someone else, you can direct them to our YouTube channel. But once again, thank you so much, Dr. Tan. So this will conclude our Lunch with Docs PD for August. And join us again, same time, same date next month. And we really appreciate everyone lending your time and your energy, and especially you, Dr. Tan. So thank you so much.
My pleasure. Thank you.
Okay. Bye, everybody.